Welcome to Pathology Central Key Concepts. The topic of this video is ischemic necrosis. Now, this is a vast topic that includes the clinical presentation, the diagnosis, electrocardiograms, lab tests, morphologic findings, gross and microscopic, and how they evolve over time. We have the clinical complications, and then the vast range of therapeutic options, not only to acute MI, but also to those downstream consequences. In addition, as you know, myocardial infarction has a tremendous impact on morbidity and mortality in the United States and beyond. And I can't cover all of that in this short video. I'm going to focus on pathogenesis, the evolution of the morphologic features over time, and the clinical consequences of myocardial infarction. Myocardial infarction is the ischemic necrosis of cardiac muscle, and the major etiology is going to be atherosclerosis. Now, the mechanism by which we get myocardial infarction can occur through three different pathways: acute coronary artery occlusion, marginal cardiac perfusion, or disorders of intramyocardial arteries. Acute coronary artery occlusion is almost always due to disruption or erosion of an atherosclerotic plaque that leads to acute thrombosis. But that's not the only mechanism. We can also see acute coronary artery occlusion when we have coronary artery vasospasm, for example, in the setting of cocaine use, or when we have an embolus, for example, from mural thrombus and atrial fibrillation, or a vegetation in infective endocarditis. Now, a second mechanism is marginal cardiac perfusion. We see this when we have a patient who has fixed coronary atherosclerosis and may be at the very edge of cardiac function. If that patient then has a sudden burst of exertion, this is going to compromise the heart and can lead to subendocardial infarcts. And I'll talk about the difference between subendocardial infarcts and transmural infarcts in a bit. We can also see marginal cardiac perfusion if you have a patient who has this fixed coronary atherosclerosis and then, for example, becomes septic and has peripheral vasodilation. Again, this can lead to myocardial infarction. And finally, as I said, we can get disorders of the intramyocardial arterioles due to autoimmune vasculitis, amyloid deposition, sickle cell disease. Let's focus, first of all, on coronary artery occlusion because that is the major mechanism for myocardial infarction. And as I mentioned, atherosclerosis is the primary cause. So what we see in this setting is we have an atheromatous plaque that's eroded or disrupted, which reveals the procoagulant substances below, subendothelial collagen, necrotic plaque contents. When this happens, platelets will adhere, aggregate, and activate. And when they activate, they're going to release thromboxane A2, adenosine diphosphate, and serotonin. This is going to cause a feedback cycle of increased platelet aggregation and vasospasm. With exposure of tissue factor, we're going to initiate our coagulation cascade, and this can result in a rapidly formed thrombus that may quickly occlude that artery. Let's take a look at what happens in our coronary arteries in the setting of atherosclerosis. And this gives me the opportunity to talk about what happens before we get to our myocardial infarction. So here we have our healthy vessel, and with a variety of risk factors such as low HDL and high LDL, we get the development of an atherosclerotic plaque. Now, this fixed coronary obstruction, if it is less than 70% of the luminal area, is going to be asymptomatic. The patient will be completely unaware that anything is occurring. However, the lumen is narrowed, so if there's a mural thrombus that's dislodged, there's a higher risk of an occlusion here than there is in a healthy vessel. Now, if we don't reduce our risk factors and there's continued atherosclerosis, we're going to get additional occlusion of this lumen. And once we pass 70%, which is considered critical stenosis, the patient will now be symptomatic on exertion. So as cardiac need increases, the patient will have pain on exertion, which will stop when the patient stops exerting. Now, again, if we continue to maintain our low HDL, high LDL lifestyle, we can end up with a severe fixed coronary obstruction, which will lead to chronic ischemic heart disease, as the cardiac myocytes are constantly denied sufficient oxygenation. Now, an important point here is that this does not lead to myocardial infarction, because as we occlude, even if we completely occlude this vessel, we're going to get the development of collateral vasculature that will perfuse the downstream tissue. What's going to take us to our myocardial infarction will be an abrupt occlusion. So let's see how we get there. So here we have our plaque, and this is one that we're going to describe as a vulnerable plaque. It has a thin fibrous cap, which is prone to rupture. We have a large atheromatous lipid core with necrotic material. This necrosis is going to bring about inflammation. Inflammation is going to cause the release of mediators that lead to matrix degradation. We're going to have decreased smooth muscle cells in this plaque, and with this vulnerable plaque, if we have, say, transient hypertension or vasoconstriction, we can get plaque disruption, and when that occurs, our platelets are going to aggregate here. So if we have our platelets aggregate and we're able to heal this quickly, then we'll move to healing, but the healing process is going to increase that obstruction. Now the two alternatives are going to result in thrombus formation. So here we get a mural thrombus to this necrotic material that does not completely obstruct the lumen, so some blood is getting to the downstream tissue. When we get this, the patient will then have what is called unstable angina. So even if the patient stops exerting and just sits still, the patient will still have pain. We will also have the possibility of a subendocardial myocardial infarction. And this is when we have the zone of tissue right under the endocardium that becomes necrotic. And I'll explain why we see that when we have limited but not complete obstruction of the coronary artery. And another possibility is sudden death. Now, the other possibility that can happen with plaque disruption is this rapid growth of an occlusive thrombus that immediately occludes this vessel, leading to an acute transmural myocardial infarction. It can also lead to sudden death. And since both of these are acute and occur in the coronary artery, they're referred to as acute coronary syndromes. So what happens once we occlude this vessel? What's happening to our downstream cardiac myocytes? So within seconds, they've run out of some of their ATP. The ATP levels begin to decrease almost immediately. This is because the cardiac myocytes depend on oxygen to generate this ATP. And even though the cells are still viable, they don't die until about 20 to 40 minutes, they're going to become dysfunctional with this ischemia, and in less than 2 minutes, they'll have lost contractility. Over time, we'll get continued reduction of our ATP, and at about 40 minutes, we're down to 10% of normal, and from 20 to 30 to 40 minutes, we get our irreversible cell injury. Irreversible cell injury is going to blend into necrosis. Now remember from the necrosis video that necrosis is characterized by disruption of the plasma membrane, which is going to allow the leakage of those intracytoplasmic proteins and contents out into the surrounding tissue and into the blood. And this is how we are going to diagnose myocardial ischemia. So as I said, at about 20 to 30 to 40 minutes of ischemia, we'll get our coagulative necrosis, myocyte necrosis, leakage of our substances, and that's what we're going to measure. So I have here grayed out creatine kinase MB isoform, also known as CKMB, because although this was used earlier in medicine, we don't typically use this in the United States because cardiac-specific troponins are much more sensitive and specific. We look at the T and I isoforms, and this is how they are denoted: cardiac troponin T, cardiac troponin I, and the role of these proteins is to regulate calcium-mediated contraction of cardiac myocytes. And they will begin to increase about 2 to 4 hours after a myocardial infarction and will peak at 1 to 2 days. They'll be elevated for about a week to a week and a half. Now we can see a difference in this depending on whether or not we get reperfusion. So remember that whenever a thrombus is formed, the body, because of homeostasis, is going to immediately begin thrombolysis, and it's possible that the clot will resolve on its own. However, for many patients, we'll give thrombolytic agents or a stent, and that will result in reperfusion very quickly, and that can cause an earlier and higher peak of our troponins due to washout of what is in the tissue. Let's take a look to get a better idea. So here we can see our heart that has had an acute myocardial infarction. Here we're looking at the cell. We see our myosin and actin chains with troponin complex to our actin. With necrosis, the proteins are going to dissociate and the plasma membrane will rupture, and troponin will be found in the blood. And we can measure this. So this shows here the typical trajectory of an individual who's had a myocardial infarction, who has had no reperfusion, has a fixed occlusion. And here's what we see in patients who do reperfuse, so after thrombolysis. Now, it's important to consider what is happening in the heart when we talk about how an infarction progresses over time. So let's work through this figure from Robinson Kumar Basic Pathology. So here we have 0 hour. So this coronary artery has just become occluded, and this area dotted in yellow is the tissue that this artery perfuses. Now remember, the artery is here on the epicardial surface, but it has penetrating arterioles that supply this tissue. There are a couple of forces that are working on this tissue. So remember that these arterioles, as they penetrate, are going to decrease in diameter. They're going to become thinner and thinner. So, and this tissue here is receiving the least amount of oxygenation because it is most distant from this coronary artery. Another factor to keep in mind is that there is pressure within the chamber that is going to further compress the distal tips of these little arterioles. And finally, we do have the ability for some oxygen to diffuse across from this oxygenated blood in the chamber and supply the first couple of millimeters of tissue. So within this first 2 hours, the tissue that's going to die first is going to be this subendocardial tissue because, as I mentioned, it is getting the least amount of oxygen from this epicardial vessel. The little tips are being compressed by the pressure in the chamber. But notice here we have that thin rim of viable tissue oxygenated from the chamber. Now, over the next 3 to 6 hours, we're going to get completion of the infarct. And at 24 hours, you can see here it's completely done. All of this tissue is dead. This is a transmural infarct, aside from this tiny rim right here. So the pattern of infarction that we see is going to depend on the size and distribution of the involved vessel, and I'm going to show you a map that gives you some of that information in a moment. The rate of development and the duration of the occlusion. So this is the saying that time equals muscle, so the more quickly we can resolve that thrombus, the better the heart will do. The metabolic demands on the myocardium. So if the patient experiences that myocardial infarction and that chest pain and remains still and calm and is taken to the hospital, that's better than someone who has that myocardial infarction and is exerting him or herself vigorously. Because that's going to put additional strain on the heart. And also the extent of the collateral supply. You can get a myocardial infarction, but if it develops in a vessel that has been slowly occluding and we have excellent collateralization, that patient's heart will be better perfused. Now, as I mentioned, we have our transmural infarcts and our subendocardial infarcts. I'm going to talk about these and then mention microscopic infarcts. So, the difference between transmural infarcts and subendocardial infarcts is clinically significant. So we see transmural infarcts when we have epicardial vessel occlusion, so complete occlusion. And the reason that we see these tremendous changes on the electrocardiogram is because that entire area of wall is necrotic. And what we'll see on an electrocardiogram will be ST segment elevation. So transmural infarcts are referred to as ST elevation myocardial infarct, or STEMI or STEMI. And this is important because transmural infarcts, as you would imagine, have a worse prognosis than subendocardial infarcts, where you still have residual tissue. These tend to affect the inner third of the myocardium because that is the most distal from those penetrating arterioles, and is referred to as a non-ST elevation myocardial infarct, or non-STEMI or NSTEMI. And we see these when we have a thrombus that does not completely occlude the vessel, when we have a thrombus that's lysed, or if we have a global hypotension, and that'll become clearer in the next figure that I show you. Finally, we can also see something which is not very common. These are microscopic infarcts. So these are small vessel occlusions due to, for example, autoimmune vasculitis, vessel spasms during cocaine use, microembolization, etc. So let's look at a map that I think puts a lot of this information together for you. Let me begin by orienting you. This is the heart with the right ventricle, left ventricle, anterior here, posterior here. Here is our left anterior descending branch. Here is our left circumflex branch. And here is our right coronary artery. Now what we'll look at first will be our transmural infarct. So we have complete and permanent occlusion of the left anterior descending branch, which is the branch that primarily supplies the apex of the heart, this area of the anterior portion of the left ventricular wall, as well as the anterior portion of the interventricular septum. By contrast, you see what we get with the left circumflex branch, where we have the left ventricular free wall here, and then with the right coronary, with the posterior portion of the left ventricle and part of the interventricular septum here. Now, if we get restoration of flow, what will happen is we will have this transient partial obstruction leading to a regional subendocardial infarct, so right just this one area here. If the patient has, as we talked about before, marginal perfusion due to 3-vessel coronary artery atherosclerosis, and then they have global hypotension, for example, in the setting of sepsis with peripheral vasodilation, we're going to get this subendocardial infarct that is circumferential. And finally, what we can see when we have these small intramural vessel occlusions is these microinfarcts. So this is the gross sort of map of what we see. Let's talk about how the heart is actually responding to what is occurring to it. So these are the morphologic findings. I'm going to focus primarily on the microscopic findings because the gross findings are somewhat hard to discern, and if we as pathologists really want to try to determine the duration of an infarct, we're going to look microscopically. So it's important to recognize that in the first 30 minutes after myocardial infarction, there can be absolutely no gross or microscopic indication that anything has happened. So if the patient has a massive myocardial infarction and has sudden cardiac death and we remove the heart, there will be no sign that anything has happened. Now, at 30 minutes to 4 hours, grossly, we still don't see very much. But morphologically, we may see a little bit of something. And that is, we'll have those necrotic myocytes, and they'll be next to viable myocytes. And those viable myocytes are continuing to beat. And they're going to pull on those the necrotic cardiac myocytes and create this waviness. These are called wavy fibers. And I'll show you an image of that in a moment. At 4 to 12 hours, the area that's infarcted may look a little bit dark. Again, difficult to see. But this is when we're going to see the onset of our coagulative necrosis and the beginning of edema and hemorrhage. At 12 hours to a day, we'll have dark mottling of this area, ongoing coagulative necrosis, which is going to include pycnosis, so darkening of our nuclei, hypereosinophilia due to the increased avidity of these denatured proteins for our di-eosin. We're going to get the neutrophils beginning to move in because that's their response to necrosis. And then there is another finding we can see, which is called contraction band necrosis. Now, we most commonly associate this with reperfusion. And what happens is you have a necrotic myocyte. And when you reperfuse, that's going to bring in oxygen as well as calcium. And what calcium is going to do is it's going to allow contraction to occur. But because we don't have ATP and sufficient oxygenation, we won't be able to use that ATP-dependent relaxation of the muscle. So we'll see what are referred to as contraction bands, and I'll show you that as well. Over the next 1 to 3 days, now is when we begin to see something grossly of interest, which is a yellow-tan infarct center. So right at the very center of that infarct. Our coagulative necrosis will continue with karyolysis, so loss of our nuclei and loss of our striations, and much more abundant neutrophilic infiltrate. At 3 to 7 days, we're going to not only have this yellow-tan center, but it's going to begin to get soft because we're going to have this initial disintegration of the dead myofibers. There'll be some hyperemia at the border. This is due to that healing response. Now, if we look at this microscopically, we're going to see the death of the first wave of neutrophils, but keep in mind that with this necrosis, there will be some additional neutrophils moving in, but most of the ones that you'll be seeing will be dying. We'll also have early phagocytosis at the infarct border. Over the next week to week and a half, this is when you're at your greatest risk of rupture, because this is when we have well-developed phagocytosis and we have a lot of digestion of that necrotic tissue, so it's incredibly soft. We also will get the beginning of granulation tissue, which, as you'll recall from the video on chronic inflammation and tissue repair, is a loose network of extracellular matrix, fibroblasts, and new capillary vessels. Oh, and what we'll see here is well-established granulation tissue at a week and a half to 2 weeks, and the increasing new blood vessels, and then collagen. Because recall that the way that infarcts will heal in a tissue that is not able to proliferate will be through scarring. Again, this is covered in the video on chronic inflammation and tissue repair. Over the next 2 weeks to 2 months, grossly we're going to see a gray-white scar, and we're going to see increased collagen deposition and increased cellularity. And finally, after we're 2 months out, when it's considered a remote infarct, the scarring will be complete, and histologically we're just going to see a dense collagen scar. So let's look through at how the histologic features evolve over time. So here you can see our wavy fibers at the border. These are necrotic cells. You can recognize that by their dense eosinophilia. And they are being pulled into this form by the viable myocytes that are adjacent. At about 12 to 24 hours, if we've managed to reperfuse, we're going to see contraction band necrosis. So here you can see these very prominent bands. Then over the next 1 to 3 days, this is probably more at the 3-day end of things, because you see that many of the neutrophils here are dying. We can also appreciate the necrosis here, again, that dense eosinophilia, and appreciate here the pycnosis, the darkening and shrinking of these cardiac myocyte nuclei. Then at about a week and a half, here's where we have our macrophages that are moving in to digest this necrotic muscle. Now you can see that we've moved on. We no longer can see the nuclei very well. There are a few faint shadows here. These nuclei have undergone karyolysis, and this dead tissue is being consumed by the macrophages. And you'll notice that there really aren't any neutrophils present here. Also at 10 days is when we have our granulation tissue, where we can have our scattered fibroblasts, our new capillary blood vessels that are forming, and then this loose extracellular matrix tissue. And you can see why this tissue would be very prone to rupture. It doesn't have a lot of architecture or structure to it. And then a remote infarct is shown beautifully here with this sheet of collagen. So this is the way that the heart tries to repair a large area of necrosis. And looking at this, you can see why we get some of the complications that we get. This tissue is not going to be able to contract like the surrounding myocytes, so it's going to have a different contractility. It's also going to, it can cause some stasis in the wall as it doesn't move as freely. And this can also be an impediment to electrical impulses, depending on where this infarct occurred. So let's take what we've just looked at with the histologic findings and talk about the complications. So I've referred a couple of times to myocardial rupture. That typically occurs, as I said, about 3 to 7 days after myocardial infarction, because that is when the heart is maximally soft. That necrotic area is at its weakness. Now, risk factors include increasing age as well as female sex. And it's more common with the first myocardial infarction, because if you have multiple healed myocardial infarctions, each myocardial infarction is going to leave behind fibrosis. And that fibrosis is going to act to hold things together. These are three examples of myocardial infarction that I cover here. So here we can see the left ventricular free wall, which is the one that most commonly will rupture, in part because about 40 to 50% of myocardial infarctions are due to occlusion of the left anterior descending coronary artery. So this is where infarctions tend to occur. And keep in mind that there is a lot going on in the left ventricle. There's a lot of force, there's a lot of pressure. And so if you have a lot of force and pressure and an area of weakness, you have the risk of rupture. And when that happens, as you would imagine, this is going to be absolutely catastrophic. It's going to result in pouring out of blood into the pericardium, which leads to hemopericardium and not uncommonly cardiac tamponade, in which the heart cannot fully expand because the pericardial sac is full of blood under pressure. This is an example of a ventricular septal rupture. And what happens here is what we see in ventricular septal defects in congenital heart disease, which is covered in a separate video. And what happens then is we're going to get left to right shunting as the high pressure blood from the left ventricle is pushed into the right ventricle. This is then going to go into the pulmonary vasculature, which can lead to pulmonary edema. And we can, over time, depending on the size of the rupture, we can get pulmonary hypertension and cor pulmonale. And finally, we can get papillary muscle rupture. So you can see here is a ruptured papillary muscle. And when that happens, you can get severe mitral regurgitation as we're no longer tethering that valve and pulling it the way it needs to be pulled. Now, there are another wide range of complications. I'm going to go through each of these. So contractile dysfunction occurs pretty much immediately, so within the first 2 minutes of myocardial infarction, while the myocytes are still viable, because even though they're viable, they are injured. And so we're going to see that the heart is not pumping as effectively, and the degree of dysfunction is going to correlate with the extent of damage. So how large is the area perfused, and what is the duration of time over which that occlusion occurred. While papillary muscles can rupture, they can also become dysfunctional, just like the rest of the myocardium, and this can result in post-infarct mitral regurgitation, even if we don't have a rupture. In addition, injury to the myocardium in the papillary muscles can result in shortening of the chordae and can eventually lead to post-infarct mitral regurgitation, even if we don't have a rupture. Now, the ischemic myocardium is very irritable and is prone to conduction disturbances, which can lead to sudden death. And the risk for serious arrhythmias, such as ventricular tachycardia, is highest in the first hour after myocardial infarction and then decreases after that. Now, in the video on patterns of acute inflammation, I talked about the fibrinous pericarditis that we can see after myocardial infarction. This is a response that we see to the necrotic tissue. It occurs about 2 to 3 days after infarction. Typically, after that, it will resolve without sequela over the next 3 to 7 days. However, if you have a very large infarct, you may end up with scarring because you'll have so much fibrin that the only way that the body can heal that is through causing a collagenous scar. Now, just as an aside, there's a second type of pericarditis we can see associated with a myocardial infarction, which is distinct from the one that we see 2 to 3 days after infarction. Dressler syndrome is an autoimmune pericarditis. Remember that when you have necrosis of tissue, you're going to get exposure of antigens, and what we can see here is about 1 to 6 weeks after a myocardial infarction, patients will present with a pericarditis, which you can recognize by a friction rub, which you can hear with your stethoscope. Another complication is chamber dilation. So when we have necrosis, that tissue will be weak, but the heart doesn't get to take a couple of weeks off and just rest. The heart is constantly pumping. So as those other myocytes are pumping and pulling, this weakened tissue may stretch, leading to chamber dilation. Chamber dilation is going to change the hemodynamics of the heart. There may now be areas of complete stasis. And what does stasis lead to? Think back to our circulatory dysfunction videos talking about mural thrombus. So this has to do with, we get an area of coagulation that forms here. And this can occur not only because we have our dilated chamber with that area of stasis, but we can also get decreased contractility due to our chamber dilation and contractile dysfunction. This can lead to these thrombi that may then be flicked up into the coronary arteries or into the cerebral vasculature. Now, another complication is a ventricular aneurysm, and we tend to see this when we have a large transmural anteroseptal infarct. And what happens here is that we're going to get this vast dilation with collagen formation. And the challenge of this is that, again, this can lead to mural thrombi as well as arrhythmias. These lesions don't tend to rupture because they have this collagenous shell. And I'll show you an image of that on the next slide. And finally, we can get progressive heart failure. So over time, with our accumulated ischemic injury and inadequate compensation, we can get what we call chronic ischemic heart disease or ischemic cardiomyopathy. Now, the heart, when it has that myocardial infarction, we're going to have the area that is necrotic and then scarred and is no longer able to contract, which means that the rest of the cardiac myocytes are going to have to step up. They'll undergo hypertrophy without a correlating proportional increase in the capillary vasculature. So as a consequence, the heart, which has already been injured, is now moving towards something which may work initially in the short term, but over time can lead to decompensation, leading us to our ischemic cardiomyopathy. Now let's take a look at some of these findings. Here we have a beautiful example of fibrinous pericarditis. You can see here it's this hemorrhagic appearance. There's another image of fibrinous pericarditis in the patterns of acute inflammation video. Here you can see wall thinning. So the wall here of this left ventricle is very attenuated. Compare it here to the regular wall thickness. And you can see here, it's a little difficult to make out on this video, but I hope that you have your very own copy of Robbins and Kumar Basic Pathology. You can find this image there. That is a mural thrombus. And you can imagine it's just a short step from, remember, there's blood under high pressure washing over this thrombus, easily taking access to the aorta, going up, causing a cerebrovascular accident or into a coronary artery, etc. And then finally, here we have a left ventricular aneurysm. So here you can see we have this profound left ventricular hypertrophy, which is going to be compensating for the fact that none of this area is contractile. So you can see here that it's quite obvious we're going to have areas of stasis because there's no musculature pushing here. And then with that, we can again quickly get access up here to our aorta. So let's finish up by looking at the big picture from coronary artery disease to sudden cardiac death and all of the steps in between. So if we begin here with fixed coronary artery obstruction, we can have myocardial ischemia that leads to our subendocardial infarct. This will be a non-ST elevated myocardial infarction. However, with anything that goes on in the heart, you may have just some myocardial ischemia, depending on where it is, can take you directly to sudden cardiac death. For other patients, we're going to have this fixed occlusion, and myocardial ischemia can lead to chronic ischemic heart disease as we get responses to this necrosis and as the wall needs to address the fact that it is not receiving sufficient oxygenation. Now with our acute plaque change, we get our myocardial ischemia of increased severity and duration, and this is going to lead to our transmural infarct, and that would be then our ST elevated myocardial infarction. And with this, we have necrosis. It's going to result in muscle loss. The stunned, injured myocardium may be arrhythmic, leading to sudden cardiac death. Or if the patient survives this, they can have infarct healing, the ventricular remodeling I mentioned before, where we have myocyte hypertrophy, dilation of the viable muscle, leading to chronic ischemic heart disease that can pass through congestive heart failure, where we get insufficient pump performance and cardiac death. So as always, I'm finishing with a few questions. Feel free to pause and see if you can answer these, and if not, feel free to watch the video again. As always, thank you for your time and attention. Please follow me on Twitter, check out my website, and I appreciate you. Thank you very much.